Good day. We'll be discussing return to work in workers with fibromyalgia syndrome and factors influencing work disability in women. So, for context, fibromyalgia is a condition that makes your body feel sore and tired most of the time. People with it often have muscle pain, trouble sleeping, and feel very tired even after resting. They might also have trouble focusing or remembering things. So there is no cure for this, but regular exercise, stress control, good sleep, and some medications can help make the symptoms easier to manage. So I'll be discussing the adjustments in workplace in the next slide. Adjustment in the work situation. Adjustment in the work situation through work accommodation and modification is vital for women with fibromyalgia to continue working. Adapting tasks to their abilities makes work more manageable and rewarding despite daily pain fluctuations. Jobs involving heavy, repetitive, or overhead work should be avoided. Helpful adjustments include flexible hours, dividing strenuous tasks, using ergonomic setups, and reducing stress by having quiet or private workspace. Allowing schedule changes based on symptoms variability also supports continued employment.
Body awareness and fitness are important techniques that help individuals with fibromyalgia syndrome manage pain and muscle symptoms. So, research has shown that rehabilitation programs combining body awareness training as well as EMG biofeedback can enhance posture and improve muscle activity. After these programs, participants often demonstrate lower trapezius muscle activity during tasks, along with decreased pain and effort. This indicates that it is more efficient or there are more efficient movement patterns that support recovery and return to work. So many women with fibromyalgia also described how practicing body awareness as well as relaxation allowed them to feel more in control of their symptoms throughout their daily life. Still, there are still many challenges like muscle weakness and pain, which often limit their work performance due to difficulty maintaining muscle relaxation and strength during repeated movements. To improve muscle function, individuals are encouraged to adapt to certain movement patterns that only use necessary amounts of muscle activity. So, by learning to move more efficiently and with less tension, they can reduce the pain and fatigue that they're feeling while gradually building endurance. So, basically, it's like you're teaching them to maximize their energy or to conserve it while doing their tasks. Physical capacity plays a key role in return to work. So basically, exercise is very important, and incorporating functional or aerobic exercises such as walking, swimming, running, yoga, tai chi, strength training are important and have been found to decrease pain, fatigue, and depression while improving physical fitness and overall quality of life.
Chronic fatigue syndrome is also known as myalgic encephalomyelitis. It is a post-viral fatigue classified by the World Health Organization ICD-10 as a neurological disease. Its origin is based on descriptions of epidemic outbreaks of polio-like disease in the 20th century with unidentified suspected infected causative factor. It is more common in women, about 60 to 70% more than men, and it can follow viral infections such as the EBV or Epstein-Barr virus or the Ross River virus. CFS is initially defined as a chronic fatigue syndrome. It is based on one major symptom, which is the severe mental and physical fatigue persisting over 6 months, and at least four of eight additional symptoms, including post exertional malaise, with the exacerbation of symptoms after mental or physical activity lasting for over 24 hours, recurrent sore throat, tender cervical or axillary lymph nodes, muscle pain and multi joint pain, new headaches, unrestorative sleep, and cognitive symptoms, including concentration and memory problems. The CFS is defined as an exclusionary diagnosis where other somatic or psychiatric disorders must be ruled out first. Causative relation to infectious disease have been debated. It is viewed as a psychosomatic disease and a biologically based disease by different groups. Based on a psychological fatigue model, it can contribute to a development of comorbid psychiatric disorders such as depression and anxiety. The CDC criteria, as I previously mentioned, is criticized for not clearly excluding mental disorders such as depression and anxiety disorders. The new Canadian criteria, which was formed in 2003, identifies patients with a more severe disease, and this will be explained more later on. Patients Patients with unexplained prolonged fatigue, not meeting all the diagnostic criteria, are usually classified as idiopathic chronic fatigue. The pathophysiology for the CFS is unknown, but there is one hypothesis that postulates that it is neuroinflammatory in nature. Reported cases were linked to post infective onset, for example, after mononucleosis or EBV. For rehabilitation, most previous rehabilitation is impeded by the application of the CDC criteria, which was not designed to exclude the burnout syndrome. Burnout related fatigue is more prevalent than post viral fatigue. Burnout related fatigue might have a better prognosis and a more favorable response to graded exercise therapy or GET and cognitive behavioral therapy or CBT. CFS or ME, on the other hand, or post-viral fatigue, has a poorer prognosis with long-standing functional impairment and activity limitations, which are not responsive to deconditioning therapy and GET.
Next, we have the Canadian criteria, which is used for the diagnosis of chronic fatigue syndrome or myalgic encephalomyelitis, also known as CFS or ME. So, this helps identify patients with a more severe form of the disease and provides a structured framework to confirm the diagnosis based on specific clinical features. So, to diagnose CFS-ME using the Canadian criteria, all six sections must be met. So, first we have post exertional malaise and fatigue. This means that the person experiences a marked degree of new onset, unexplained, and persistent fatigue, both physical and mental, that significantly reduces their activity level. So, they also experience worsening fatigue, malaise, or pain after exertion, with a delayed recovery period lasting over 24 hours. And second, we have sleep disorder. Patients typically have unrefreshing sleep or altered sleeping patterns, which may include disturbances in their circadian rhythm. So third, we have pain. They may experience muscle or joint pain without any signs of inflammation and often develop new types of headaches that differ in pattern or severity. So next, we have neurological or cognitive manifestations. So at least two symptoms must be present, such as difficulty concentrating, poor short-term memory, problems processing information, or sensory overload, like sensitivity to light or noise. So some may also experience perceptual disturbances, disorientation, or problems with coordination known as ataxia. So fifth, we have autonomic neuroendocrine or immune manifestations. So the patient must have at least one symptoms in two or more of these categories. So under autonomic, symptoms include orthostatic intolerance, dizziness, irregular heartbeat, or problems with temperature regulation. Under neuroendocrine, there may be issues like heat or cold intolerance, appetite and weight changes, or poor tolerance to stress. And under immune, symptoms may include tender lymph nodes, recurrent sore throats, flu-like feelings, or allergies and sensitivities. So next is illness, which must persist for at least 6 months for it to be diagnosed as CFS or ME. So this Canadian criteria ensures a comprehensive and specific diagnosis, helping distinguish true CFS or ME from other fatigue-related conditions.
So return to work among women with chronic fatigue syndrome and myalgic encephalomyelitis. So key demographics and impact, we have female predominance, which is 73 to 82% of ME and CFS patients are of women. And peak working age affected is most patients in their prime working years between 18 to 69 years of age. And for severe employment impact, there has been 50 to 54 unemployment rate among ME and CFS patients, and 71 are of partially or fully medically retired, and 37% reduction in employment for both women and men with ME and CFS. So for economic burden, lost productivity, approximately $9.1 billion annually in the United States, and individual loss approximately $20,000 per person annually. Greater impact on women. So 42% of household productivity loss also, while 63% are of labor force productivity loss. So going next to the return to work outcomes and predictors. So return to work success rates based on longitudinal studies. Remain employed, only 53% of those working at baseline maintain employment. So it's grabe, you know. So return to work, only 9% of those not working return to work at follow up. And next is lost employment. 6% of those working at baseline became unable to continue working. And long-term outlook is after 4 years, 43% remain unable to work despite interventions. And next we have predictors of poor work outcomes. So first we have your strong negative predictors. So the first one is CFS like status at baseline. So 3 to 4 times more likely to be unable to work long term. So next is older age at illness onset, greater fatigue severity, higher functional impairment, severe depressive symptoms, and next is your cognitive and behavioral responses to illness. So a key finding to this is physical dysfunction, not fatigue alone, is the ultimate arbiter of work capacity. So, work patterns and rehabilitation implications. So, characteristics of those who return to work. So, reduced hours. Working patients averagely only 20 hours per week. So, part-time predominance also. Most work part-time rather than full-time. They prefer, probably because their body cannot handle the amount of work. So modified duties. So required physically less demanding jobs. So next is workplace needs. So flexible working hours for fluctuating symptoms, accommodation for travel, time to and from work, rest breaks, and reduced workload. So next, we have your clinical and rehabilitation recommendations. So, important considerations, you know. So, poor prognosis. So, if on long-term sick leave greater than 2 to 3 years, return to work unlikely. So, treatment limitations are usually CBT and graded exercises, therapy do not restore work ability. And yeah, disability recognition. So, physical capacity loss is the primary barrier, not lack of motivation. And next is early intervention needed, so target work outcomes before prolonged absence occurs. And lastly, realistic expectations. Many patients will eventually require medical retirement.
According to Kearns and Hotoff in 2005, research on work disability in CFS or ME is limited compared to fibromyalgia. Among patients with CFS, the median full recovery rate was only 5%, while 39.5% showed improvement. The return to work rate ranged from 8 to 30%. From a rehab standpoint, the authors recommended postponing medical retirement until appropriate rehabilitative interventions have been tried. Although the proportion of women was not specified, it is likely that most participants were female, as CFS or ME is more common in women. In a follow up study by Leon and colleagues in 2006, 56% of fatigue employees were women and 26% were receiving work disability benefits after 4 years. Older age, female gender, and lower physical functioning predicted greater work disability. Similarly, Hubers and colleagues in 2006 found that individuals with CFS like symptoms were 3 times more likely to be unable to work after 4 years, indicating that a CFS like status strongly predicts long term work incapacity.
Research shows that women with CSF are at greater risk of being unemployed or unable to work due to their symptoms. They not only deal with fatigue and brain fog, but also face the added pressure of household and caregiving duties. These overlapping roles make returning to work more complex for women. Research shows that women with CSF are at greater risk of being unemployed or unable to work due to their symptoms. They not only deal with fatigue. The most effective return to work interventions for women with CSF are those that combine flexibility, energy management, and collaboration between all involved. Because fatigue and post exertional malaise can worsen with overexertion, flexible work arrangements are essential. This could mean reducing the number of work hours, shifting to part time or remote setups, or adjusting job duties to match the worker's current energy level. A gradual return to work program is also effective because it allows them to start slowly and increase their workload only when their condition improves. This prevents burnout and builds confidence over time. Educating employers and coworkers about CSF or ME is just as important, since awareness encourages understanding and cooperation instead of pressure. Lastly, when doctors, therapists, and employers work together with the patient, the plan becomes more coordinated and realistic. With the right balance of support and flexibility, women with CSF or ME can return to work safely and sustain their recovery in the long run. Successful return to work outcomes for women with CSF or ME depend on teamwork among the woman herself, her doctors, and her employer. Women should be aware of their limits and not feel pressured to perform beyond their energy capacity. Prioritizing rest and communicating honestly about what they can and cannot do helps prevent flare ups and build trust with employers. Employers play an equally important role as well. They should provide flexible schedules, allow breaks when needed, and avoid comparing the employee's pace to others. Understanding that recovery takes time creates a more positive and sustainable work environment. Healthcare providers and rehabilitation professionals should monitor progress closely and guide patients on pacing and workload adjustments. They can also serve as a bridge between the patient and the employer to make sure the work plan stays realistic. When all three, the patient, the employer, and the healthcare provider work together with empathy and flexibility, women with CSF or ME have much higher chance of returning to work successfully and staying well over time.